Good evening, doctors and all participants. I'm Dr. Izin Kusop, again, the Vice President of Association of Private Practitioners Sabah, APS. Welcome to our free live streaming webinar. During the session, if you have questions, please write them down on the comment section in the YouTube platform, and they will be addressed by the speaker at the end of the session. Our speaker this evening is Dr. Chan Kan Wei. Good evening, doctors and all participants. I'm Dr. Izin Kusop again. Dr. Chan Kanway graduated from National University of Malaysia, UKM, in 2003 and was conferred the Royal Award of Outstanding Performance. He completed internship in Queen Elizabeth Hospital and Masters in General Surgery under UKM. He obtained fellowship in Bariatric and Metabolic Surgery in Taiwan, fellowship in Colorectal Surgery in Taiwan, diploma in Laparoscopic Surgery from University of Strasbourg, France. He is certified Advanced Trauma Life Support Provider and Instructor. He is also a member of Endoscopic Laparoscopic Surgery of Asia, ELSA, member of International Federation for the Surgery of Obesity, IFSO, International Bariatric Club, IBC, Society of Endoscopic Laparoscopic Surgery of Malaysia, SELSMA, and Malaysia Metabolic and Bariatric Surgery Society, MyMBS. He offers general surgery services, advanced laparoscopic surgery for upper, GIT, and colorectal diseases, both for benign diseases and cancers, gallstone diseases, and abdominal and inguinal hernias, and many other surgery. He currently works in Gleneagles Hospital, Kota Kinabalu, Sabah. The topic he'll be delivering today is bariatric surgery. Ladies and gentlemen, Dr. Chan Kanway.
Hello, good evening. Good evening, everyone. Thank you very much, Dr. Rizin and the AEPPS for inviting me to share about this topic of what I do currently in Gleneagles, Kota Kinabalu. So I'm here to talk about bariatric and metabolic surgery for the treatment of obesity and type 2 diabetes mellitus in terms of surgery. Hold on. Trying to move my slides. Okay, as we all know very well, obesity is cropping up all over the world, especially in this part of the world. Not only Southeast Asia, but also Malaysia, as we are one of the top in terms of the numbers of obesity, the obesity rate in Malaysia, and we are talking about obesity of nearly 15% of the population with overweight, of another at least 30%. And we know it's very interrelated to diabetes mellitus. At least 2 out of Malaysians who are more than 18 years old are suffering with diabetes, and it's very much associated with with obesity, the kind of food, lifestyle, the society trend, and especially in these past 2 years, we have the rise of the pandemic COVID, and we know obesity is one of the high risk factor for the severity of COVID, and the awareness of obesity as a disease and where there is treatment for it is made aware to the society. So, is obesity a disease? The answer, of course, is yes. It's not a weight issue. It's actually more complex than that. Being overweight or obese poses a lot of health risks, including especially diabetes mellitus. We're talking about obstructive sleep apnea, high blood pressure, asthma, osteoarthritis, and so on and so forth. And we know the benefits of just some weight loss of at least about 5% will bring down the level of HbA1c, of course, the blood pressure. And how do we treat obesity? So over the years, we've been trying to advise patients in terms of dietary advice, exercise, better lifestyle, and we know it is not really working because we can see the rise, the rise of the rate of obesity is coming up. It's somehow not, it doesn't really work. And we have tried some drugs as well, whether it's over the counter or prescription drugs, but of course it comes with its own limitations. One of the most common drug that we can find here is phentermine, in terms of it's some kind of symptomatic. We know it can bring down some weight loss, up to 10% of body weight if they take it for over a year. But by all means, you must know this.
Oh, habis bateri.
Obviously, I use reasons.
Sejam. Also low back. Sekejap, I charge. Okay, try to continue.
Can continue. So can continue. Can hear me. So of course, we must always advise our patient about healthy diet, eating less and healthy diet. So which one is more important? We know the answer. Healthy diet, definitely. And we always talk about calorie countings and whatnot. But we should know calories comes in many forms, and I myself per se would divide them to bad calories and good calories. Bad calories are those coming from sugars, all sorts of complex sugars like what we see today. Uh, what I put up here is the common things that you'll find everywhere now. Here, even in KK and home Malaysia, we are a source of very good food, and most of the source are, I would say, bad calories. They give you a lot of good calories, but these are not going. If it's not even utilized, you can definitely deposit it as fat. That's where you have fatty liver, increase of visceral fat, and so on. How about exercise to lose weight? For obese patients, we are talking about BMI of 40, 50, 60s, where their weight are above 100, 150, 200. Exercise would be detrimental if you try something not recommended. Like we see nowadays in the gym or fitness coach, they are not tuned to guide obese patient to work out or exercise. It is mechanically very straining and harming to their joints, to their heart. And even some fitness coach had advised our patient to have water therapy. They drink up to 5 liters of water per day. We actually seen patients with chronic heart failure because of that. And one example of, do you know where it is now? Let's leave it. So one example of what happened in the US back in 2016 was the announcement of the Biggest Loser in America. So they have this all contestant went into a 3 months camp full of coaching, exercise, dietary punishment, and all. And yes, they did. Did they lose their weight? They did, and some lose up to, you know. Okay. they were successful, and you can see in this graph here, in the 3 months they lost majority, in fact all of them lost weight, and then but what happened after that was they followed them up for the next 6 years, and they found that all of them gained weight. All of them gained weight. Means some of they went back to their usual routine, their usual lifestyle, their usual eating habit, their usual eating source of food. And except one actually did not went back to their previous weight or even more. And actually, this patient went through bariatric surgery. I'm trying to click here. So, what is obesity? Is obesity some kind of cosmetic issue, or looks, or and which everyone is stigmatizing them, or is it something like genetic or metabolism, age, and or is it an environmental issue? Actually, it's complex. It's much complex, and it's multifactorial. It's chronic. It's a metabolic disease by itself, and it's done by excessive body fat deposition, not muscle mass, but just body fat deposition, excessive. And we recently we come to understand that the body seeks some kind of hemostasis in all our regulation, including your liver cells, your red blood cells. And fat is actually regulated. There is a hemostasis for that. And this hemostasis is governed by a weight metabolic set point in the hypothalamus. So when anyone, regardless of its weight or BMI, try to reduce their diet or try to increase their exercise, there will be hormonal regulation controlling us to try to restore back to that weight set point. So whether you are 70 kilo today or 80 kilo in future or 100 kilo, it is difficult to modify that weight, whether you want to increase it or decrease it. And it is complex, and we found out there are hormones in the GI tract that governs this very well. One of the main one is the hormone ghrelin, which is found in the stomach, especially in the fundus. Ghrelin is actually a hunger hormone, which are produced when there is an empty stomach here. So, and then there is a satiety hormone, the PYY or the GLP-1 and CCK, which will give signals back to the brain to stop a person from overeating. And there is a hormone dysregulation, which over a period chronically will give rise to obesity. So body fat mass points is affected by abnormal dietary constituent these days, unhealthy muscles, sleep depression or stress, disrupted circadian rhythm, and weight gain inducing medication. For example, one is actually insulin or even some antidepressant. And we will try to regulate by healthy diet, regular physical activity, better sleep, stress reduction, stable eating patterns, and probably some weight stabilizing alternative. But these are of minimal effect. It is good, but still minimal effect. And there are anti-obesity medications, but only one or two may work better. And we know the most profound effect come from bariatric surgery, which we'll come to talk further. And we found that only bariatric surgery can break this cycle of this weight metabolic set point. It is not permanent, but there will be a transient break of the cycle, and you will allow the body to adjust to support the weight loss and sustain that new body mass point. So one of the most standard or classic surgery is a gastric bypass. We call it a Roux-en-Y gastric bypass. So what you see on the left before surgery of anyone is the esophagus becoming the stomach and becoming the small bowel. And the stomach being a reservoir can be modified to be a gastric pouch, a small gastric pouch. And we're talking about only about 20 or up to 40 millimeters of gastric pouch, which probably the size of an egg, can be modified, partitioned to such, and we can reconnect the small bowel to the gastric pouch, and we can actually bypass a certain portion of the small bowel, even up to 50%. So mechanically, we should see the food intake will be less. So there is a mechanical reduction of food intake, And also there is somewhat malabsorption purposely induced. So you have to look at obesity as a very efficient nutrient absorption. So this surgery, what it does is to reduce the efficiency, to normalize it. So why I say that? Because later we'll be discussed about what is the side effects of this surgery. So what we're trying to do is to normalize the absorption to rather to sustain the 200 kilo body weight to probably go down to about 180 kilo body weight. So this is gastric bypass, and it's been in the world for more than half a century now, more than 50 years. And along the years, over the years, other new surgeries have came up. They have up to even a sleeve gastrectomy, where it modifies the volume of the stomach without causing any absorption. And there are other bypass procedures as well over the years. Why is that so? If someone asks, I will tell further. I'll come back to that. So another common surgery is these days we can see throughout the world is we call it a mini gastric bypass. It's only a one anastomosis bypass. Technically, it looks simpler. So you still create a gastric pouch, and we still do a bypass of the small bowel with only one anastomosis compared to the previous two anastomosis. So technically, it's different, and the outcome may be different too, with different side effects. If you want to ask later. And the most common surgery nowadays is actually what we call a vertical sleeve gastrectomy or a sleeve gastrectomy. So what it does is to remove a large portion of the greater surface of the stomach. So diagrammatically, you can see it modifies the shape of the stomach to like a banana shape, a banana-sized shape. And if you may ask, we actually remove up to 80 to 90% of the stomach volume. So what is left is actually 10 to 20% of the stomach. And that part which is removed, bisected, is actually removed. And so this surgery itself makes it not reversible. All right, just to note that. And then there is also other kind of modification. This is a sleeve gastric with a bypass of the small bowel below. And this is gastric plication, where we reduce the stomach size, but you may not have so much of a metabolic effect. It doesn't reduce the ghrelin hormone as profound as the other surgeries. Okay, so over the years, we know this surgery it will bring about a long-term effect, not short-term. So this is from a Swedish study of more than 5,000 population of trying to go through a weight loss program. And you see, by lifestyle and medication alone, yes, they can bring down the weight in the first year. But if you follow up the patient for the next 10 years, they only get to reduce about 2% of the body weight. 2% means it's about 2 kilo out of a 100 kilo person. It is not significant. And there's gastric banding, which has not been practiced in most part of the world now, and gastric bypass. Sustainably, over 10 years, it can bring down nearly 1/3 of a body weight. Means if it's a 150 kilo patient, he can probably maintain up to 100 kilo after 10 years, which is very good. So how does it work? It's not only a mechanical effect of the surgery. It's not a mechanical surgery. We say it's a metabolic surgery. So there is changes of the hormonal effect, the physiological effects of the body, of how the gut-brain system works by reducing the hormone ghrelin dramatically and increasing the GLP-1 and PY hormones, which have its own anti-diabetic effects. And it's actually more complex. There's decrease of appetite drive, altered food preference. Some patients have, a lot of patients, up to 40% may have change of their taste and smell. Actually become more sensitive. There's increase of brown or beige thermogenesis. There's some change of a signal through MC4R and LABA. There's increase of circulating bile salts in the blood circulation. There's also altered luminal bile acid pool and altered microbiota in the guts, and so on. And but it's more than just weight loss. What we see, there will be a change of a metabolic component across the body, and what we want to see most is the resolution or remission of diabetes mellitus. At least 83% And there will also be resolution of fatty liver, obstructive sleep apnea, high blood pressure, and of course, osteoarthritis, to name some. So what I want to highlight here is a trial which was published in 2016. It's called Stampede trial, where there were 150 patients divided into 3 arms, and they were all given best medical therapy for one, and one third had gastric bypass and one had sleep gastrectomy. And all these had type 2 diabetes mellitus, randomized to intense medical therapy alone, or with gastric bypass or sleep gastrectomy, and with a primary endpoint of HbA1c less than 6.0%. So in the first 12 months, what they saw is who achieved the most was the one in the gastric bypass, up to 42, or nearly 50, but half of the patients in the gastric bypass group. And sleep gastric was quite near, and medical therapy could only reach, only 12% could reach that HbA1c of 6.0, a very tight figure. And over 5 years, they continue to monitor the patients, and both sleep gastrectomy and gastric bypass patients could maintain a lower HbA1c of at least less than -2 or -2.5 from the original HbA1c level. And what was more compelling was in the gastric bypass group, at least 45% could wean off their medication, anti-diabetic medication, whether it's insulin or even the oral diabetic agents. And how does it happen in this reduction of blood sugar in the long term? Of course, there is calorie restriction from the bypass group or even the sleep gastric group. With strict calorie restriction, of course, the blood sugar level will go down. But we know there is increase of GLP-1 in terms of the changes of the hormonal physiological effects of the surgery, and of course, weight loss. There is a reduction of this insulin resistance by reduction of fatty cells. And because of these compelling results, this metabolic surgery, which is bariatric surgery, but because there is a metabolic component, it is coined as metabolic surgery, is recommended by the International Diabetic Group for treatment of at least class 1 to class 3 obesity. All right. So those who are at least class 2 and class 3 are considered or even recommended for metabolic surgery. Class 1 obesity means BMI more than 30 in the Caucasian population, but in Asia, at least 27.5 BMI and above can be considered for metabolic surgery. As is mentioned here, for Asians, we bring down to 27.5 as class 1 obesity. And for those patients who are not diabetic at the point of time, even if they undergo bariatric surgery, there is a reduction in the risk of developing diabetes itself over the years. And how about prolonging life? We found out that because of reduction of the comorbidity after bariatric surgery, a lot of the metabolic component has been reduced or even in remission, and therefore has found to have prolonged life. Right, this 12 years follow-up. And how about the safety of bariatric surgery? Because these days bariatric surgery has been done keyhole or laparoscopic or minimally invasive compared to open surgeries more than 30 years ago. For the past 20 years, it's been done as a minimal invasive surgery, and the outcome has been very good. Complication of bypass itself is low. You're talking about 0.4%, and mortality is less than 0.2%, compared to gallbladder surgery. Up to 1% may have complication like bile duct injury and whatnot. So it is safer, even though it seems so complex. But the way we screen patient and the way we perform the surgery, and of course with the anesthesia, it is much safer these days. So how do we prepare patients? Indication for surgery so far is adulthood from 18 to 65 years old. But even I've done patients who are even 17 years old, as long as they understand the procedures and they need the procedure, then the parents consented, and we did a couple of young patients, and BMI more than 35 without diabetes mellitus, and if they have failed non-surgical intervention of weight loss. There's no fixed period of how long they should try that, 3 or 6 months or 1 year or 2 years, no. But whatever intervention, non-surgical intervention they want to embark in, please do not harm themselves. Do not harm themselves. Do not ask them to climb stairs or go for a run, marathon, no, or gym even. Contraindication, patients who have cancer, organ failure, especially heart or lung or liver failure, definitely not indicated. Major psychiatric disorder like schizophrenia is definitely, we will try, definitely don't want to embark on surgery. Major depression, if they are well controlled and evaluated by a psychiatrist, or even if they have previous laparotomy because of a surgical technicality, it might have additions and whatnot. So not too many. And then the patients are actually seen by a team of including the surgeon, the bariatric dietitian, fitness coach or physiotherapist, where our anesthetists, they have to see an endoscopist to routinely, we do check the stomach, we have an upper endoscopy. We do have a bariatric physician in Gleneagles. Radiologists will come about if there is such complication that we need some kind of intervention. Bariatric nurse also very important, and psychiatrists or psychologists when in need. And we talk about patients who have diabetes. So one thing, the way we approach patients who are obese with diabetes, the surgeons try to find ways to score them, score diabetes, because there is severity of diabetes depending on how long they have been having the disease, how well controlled, and how well their pancreatic function is, or not. So we use the diabetic duration, diabetic meds, insulin use, glycemic use, and from there we can actually score them mild, moderate, severe. This is only one of the scoring system. And from there we might suggest a certain procedure like gastric bypass or non-bypass or even sleeve, just to touch on this. That's why across over the years, many types of surgeries have developed. So the answer to this is why there is so many procedures, because none of the surgeries are perfect. So some are better, some are not. Some have more side effects and some has less. But to be fair, all surgeries are quite good. All type of different modification are good. But because of different patient profiles, some are more obese, some are less. Some has more severe diabetes, or some are not. So it is not one surgery for one patient, for all patients. So in fact, we will actually assess and see which one are more suitable. Some has more anti-diabetic effect. Some has more weight loss effect. That's why across the board, there will be many types of surgery. And as I said, these surgeries are no more done by laparotomy. We rarely do laparotomy for this surgery because of their comorbidity and their weight issues and all. And if they were to have gone through laparotomy, most likely they'll stay in hospital for at least 2 weeks. But if they are done by keyhole surgery, laparoscopically, whether it's 3 or 4 or 5 keyholes, most of the patients actually stay in hospital for 2 or even 3 days. They can have the surgery today, admission today, surgery today, and majority actually go back tomorrow, the next day. Whether it's a bypass surgery, whether it's sleep gastric being the most common surgeries these days for many reasons, technical issues and selectivity of patients. This is one of the pictures. We had a fitness coach who was trained to help patients who are obese, whether it's pre or even after surgery. And you can see not all of them will be on the treadmill, not all of them will be cycling. Some already have developed OAs over their ankles and knees because of the chronic overweight and obesity. They were probably doing hand cycling. You'll find exercise which is tuned to them. Do not find exercise which can be more harmful to these patients. So what have we achieved so far in Gleneagles, our team? We have done more than 250 surgeries of bariatric metabolic surgery. Bypass procedure being about 40%, majority is still about just sleeve gastrectomy. And there are more female patients than male. And our weight range has been from 70, which is BMI 27, to 210 kilo, but BMI more than 70. And age, as I mentioned, the youngest was 17 and the oldest we had was a 60-year-old patient. And 1/3 of the patients were diabetic, And what we saw is 95% remission of all these patients. With remission means normalizing of HbA1c of less than 6, and majority actually off their medication. Hypertension itself, 42% of the patient with 80% remission and off medication. Obstructive sleep apnea, we do routine sleep study for these patients who are high risk for obstructive sleep apnea, and almost 100% remission within 2 months of the surgery. But just to let you know, this patient who has metabolic component, diabetic, hypertension, they still need to have continued follow-up. I mean the non-surgical part, because they already have gone through a period of their life with diabetes or hypertension with their own complications. They definitely need to be monitored for the years to come, and to see whether there is a recurrence of these metabolic issues. So, yeah, this is a previous slide from a previous slide. So what we had a few minor complications. We have a couple of sleeve leak over the past 6 years now. We have small bowel perforation. We also have internal herniation after gastric bypass. And one of the patients we had to redo their bypass because the bypass length was too long, and we can actually go in for surgery again to shorten the bypass because there was some protein malabsorption issue. The patient had some form of nephrotic syndrome disorder. And so far in our patient, more than 250, we have so far no mortality. Patients are quite well, and majority are being followed up well. This is one of the picture of the first patient I did in this bariatric surgery back when I was still in Queen Elizabeth Hospital. It was 2015. She was a 60-year-old grandma, 125 kilo, BMI more than 50, and she had a mini gastric bypass done. And this picture is actually a picture of her one day after the surgery. And she was prepared to go home. And this picture is, of course, already more than 1 year. And her weight was about 75. I last contacted her, and she's doing very well. One of the patients in Gleneagles, a BMI more than 50, with weight 144, height 1.7 meters. Failed weight loss, lifestyle medication, uremia of 3 months. And he has hypertension, hypercholesterol, OSA on CPAP, poor quality of life, and social stigma. He had a sleeve gastric with a modified proximal jejunal bypass, the PJB means here. So it's a modified sleeve with a bypass component, about almost 6 years now. And this picture is after 12 months. From 144, he came down to less than 90 kilo. OSA resolved within 2 months. Of course, resolution of the ankle and knee pains, and easier to exercise and less social stigma. One of our thinner patients, she was only 80 kilo, and she was 39 when we saw her. And she was already 10 years diabetic on insulin, and HbA1c of 12.2, very poor control. And we actually sent for serum C-peptide. It's one of the serum markers of pancreatic function that we see. So 3.3 for us is still quite a good functioning pancreas. She had gallstone, hiatal hernia, she has GERD, high cholesterol, and BMI 36. So she's not a really heavy diabetic, but more of a thinner diabetic. And so she had the same surgery, sleeve gastrectomy, with a proximal jejunal bypass portion. Because of a diabetic component, we added a bypass component into the surgery. And after 1 year, from 80 kilo, she reduced to 70 kilo. But the amazing thing was that HbA1c could drop from 12.2 to 5.2% without medication for at least 5 years. So the weight reduction was not significant, 80 to 70, but the remission of diabetes was very significant. And cholesterol also came down. And she was still tightly followed up by the physician or family physician, back even Lada too. And because we have to maintain that if there's recurrence of diabetes, and also of course his previous complications. One of our heavier patients, a BMI 64, weight 185 kilo, only OSA hypertension, and he was able to reduce his weight with a gastric bypass, and after 12 months, about 100 kilo, and now I think it's about 90 kilo now, and still maintained. And this was, I think, it's already more than 4 years. And one of our heaviest patients, he was one of arm wrestling champion from Gleneagles, and BMI 72.6, 205 kilo. We did a gastric bypass for him, and last check, his weight is less than 90 kilo now, and well maintained. So in summary, obesity is a disease which leads to multiple metabolic disorder, comorbidities, and shortened life expectancy. Right? Bariatric and metabolic surgery is a treatment of obesity and type 2 diabetes mellitus. Significant and sustained weight loss is able to be achieved, and resolution and remission of comorbidities associated with diabetes mellitus in almost all our patients. Bariatric surgery is only part and parcel of bariatric care by a multidisciplinary bariatric team. And a good team and center is the key to success. All right. Thank you.
Thank you very much, Dr. Chan, for that very informative and interesting presentation. Dr. Chan will address the question in the YouTube chat platform soon. We don't have question yet at the moment. While waiting for the question, I have my own question. Ask Dr. Chan.
Sure.
Okay. First of all, I think everybody, all of us GP would like to know the rough cost of this procedure so that we can give some ideas to patient when they actually asking us.
Okay, there's in terms of cost, there's two parts of the process towards the surgery. One is the pre-operative assessment, and of course, and one is surgery itself. So pre-operatively, at least I would want the patient to have an upper endoscopy done. Upper endoscopy and this basic blood test and some pre-op assessment. So that mentioned ultrasound scan. That mentioned that would cost about maybe about 3,000 plus, all right, around there. Then the surgery per se, because it is made a short stay, 2 to 3 days only. We do not get the patient to be admitted 2 weeks or at least more than a day prior. The total cost of surgery, whether it's a bypass or non-bypass, will be around 30,000. So far we see, without factoring inflation.
Okay. All right, that's good enough, around 30,000.
So
30K.
all lump sum will be probably less than 35.
Okay.
Yeah.
In Sabah, is it only Gleneagles doing it?
Yeah, so far in Sabah is only Gleneagles.
And only you doing it?
Yeah, only me doing it. Yeah. Because this is a very specialized procedure.
Exactly.
Yeah, very specialized. So I think the team also is very important. So our anesthetists, the few of them are very good, very capable, and very familiar with the patients now. Yeah, of how we do it. Even our physicians also, know how to take care of them. And it's not only the medical part, there also the social part, the emotional part, even the counseling part by the dietitian or even, it's very important.
The whole thing. How long this team has been established in Gleneagles?
I would say since it opened, in fact, our first patient was in late 2015. So it's actually coming to 7 years now. It's coming to 7 years now. Yeah.
And you got 250.
More than 250 patients. And in fact, last year the total number of patients was the most. Okay. Over the years, for many reasons. I think the pandemic was a wake up call for a lot of patients to get their weight reduced.
Definitely, yeah. Excellent. Okay, we got one question now from Dr. Asmara. Do you recommend this surgery for child obesity? And then the question number 2 is, what age of obese child usually suitable for this surgery? I think you mentioned that in the
invitation. Yeah, I mentioned in the slide that 18 is we perform this surgery for adults, 18 and above. But having said so, my youngest was 17 years old, and that was about 4 or 5 years ago already. And in the world, doing bariatric surgery for a child is not so much accepted yet, because they're still in a growth stage, and the non-surgical approach is more recommended, and they're still in the growing, as I say, in the growing stage. However, having said that, one of the highest numbers of bariatric surgeries done in the world is actually India, and we really have seen them doing the youngest, having a youngest patient there was about 10 or 12 years old, having going through the surgery, because I think the obesity condition was too much for medical to handle. And so it's something of a gray area which we are not embarked, especially in this part of the world.
Alright, fair enough. Okay, no question yet at the moment. Yeah, I still remember when I was doing my surgical attachment long time ago.
In Queen?
In Queen, yes. Are you Sabahan, Dr. Chan?
No, I'm originally Malaccan.
Oh, okay,
Malaccan,
okay.
but ever since
But you did your
graduated,
houseman in Queen.
nearly 20 years now.
Okay.
We do open appendix, my lord, we will be scratching our head, and how much, up to 4 inches of fat we need to go through. Up to 4 inches of fat we need to go through. If you imagine if it's open surgery, the extent of the wound we need to make. But for keyhole, we have devices that are catered for obesity. So, like in laparoscopic surgery, we use pots, plastic pots. So for obese patients, we actually have extra long pot.
Okay.
Extra long, and even our instruments are extra long, longer by 20%. From the camera system to the instruments are extra long. So these are specialized instruments. So quite comfortable.
Okay, so that's make the difference.
Yeah, and it's
Keyhole surgery.
and we see the rapid recovery after surgery or the next day, and they are very keen to go back home. From whether it's a gallbladder or appendix or even bariatric surgery. Yeah.
In your practice, have you actually encountered people going for it under their company insurance or
Yes.
somebody else paying for them?
Some companies or corporate actually covers very well, even for bariatric they recognize it.
Okay.
One of it is actually Sabah Electric. Thank you, Sabah Electric. Please.
Wow.
Some corporate actually do that, cover for them. And then, but it must let you know, it's still a grey area. Bariatric surgery or metabolic surgery is already in the Malaysian diabetic guideline, let alone international. So the question is why the insurance are not covering, or the private healthcare is not covering yet, because it's still a grey area. It's still, we're still talking to them for many years now. So bariatrics, if you talk about corporate, most of them will cover, especially SCSB. But with private insurance, they at the moment they do not cover bariatric per se, the bariatric part. But if you look at the whole bariatric care, whether it's from the pre-op or even intra-op, it's quite complex. So there are some non-bariatric component, and some might actually cover the private insurance. So whatever cost I mentioned just now, some part may be covered. We can apply for that.
Good to hear. All right. Okay. Next question from clinic doctor. Hang on. Dr. Asmara again. In Semenanjung, where do you recommend to do bariatric surgery?
In Semenanjung, whether it's from KL to Penang to Malacca, any center with a good bariatric surgeon and a good bariatric center. Yeah. Often I can't tell you where to go, but I think most of universities have. I think quite a few number of private centers they have bariatric services.
Government are not doing it yet.
Only certain handful of hospitals they do cover. Yeah, they do.
Alright. That's certainly a very interesting topic actually, Dr. Chan.
Yeah.
I haven't encountered any patient who wanting to be referred, but I have a lot of patients with overweight, obesity. So
yeah.
now I can mention it to them.
Yeah,
And
yeah, yeah.
if they have money, then
Yeah.
probably it's a very good idea. One thing I didn't know was when you said it's actually a metabolic operation instead of
Yes.
a mechanical operation.
Yes.
So it actually change you metabolically,
Yes.
hormonally.
Yes.
Oh,
Yes.
that's something I can use
Yes.
to actually
Yes.
persuade my patient to consider it.
Yeah, especially the metabolic part if they are diabetic, you know. So, of course, we say there is remission of diabetes, and the earlier the diabetes, the better. I mean, means the mild diabetes. If it's end-stage diabetes, so you don't expect a good remission of diabetes. Maybe they can reduce their dosages of insulin or their oral medication and reduce their weight, or even we even have patients who have already end-stage renal failure. We have patients who are end-stage renal failure, who are obese and diabetic, and they go through the surgery. The dialysis part becomes very much easier because they are restricted of the fluid, for example. Yeah, yeah. So we see improvement in that. So one of my counterpart is actually a nephrologist in Gleneagles. He's been covering our bariatric patients a lot, and we see the good effect of it. Yeah, the metabolic component.
Excellent. Okay, we don't have any more questions at the moment. I think we will end the webinar soon. Thank you again, Dr. Chan, and thank you for all participating tonight webinar. Please scan your QR code for your CPD point. If you have trouble scanning the QR code, you can register your name at the link given earlier in the chat group, and your name will be awarded 1 point later on. Thank you to our secretariat, Mr. Adrian and Ms. Melissa, for their assistance. Thank you to our sponsors, Remedy Kuala Lumpur International Healthcare Centers and Gleneagles Hospital.
This one question.
One question, okay, Dr. Asmara. So I can recommend to my obese uncontrolled diabetic patient to do bariatric surgery for diabetic control?
For that, for uncontrolled diabetic, definitely. Same, we will assess the patient preoperatively, and definitely we will optimize patient. Within days, we can optimize patient for an operation, and then yes, will be highly recommended. But the assessment will tell us whether how much patient will improve in terms of diabetic control later on remission. I wanted to let you know, all our patients who are diabetic, we actually take off their medication right after surgery for at least a month. So we give them a month, and then after that we'll reassess their HbA1c and all, and then only we see whether they need some more medication. So it's in terms of titration back again.
Sure.
So the majority actually can get off medication, but we still want them to be monitored of everything, their blood tests and whatnot. And definitely they need supplements. They need vitamins, multivitamin supplements for life. Yeah.
Definitely. How intense is the follow-up soon after the surgery? I mean, it's like
Surgeon-wise,
daily.
no.
Twice.
For my side, as a surgeon, I will follow them 3 monthly for the first year.
I'm talking about the diabetic post-surgery, post-bariatric.
I mean,
the follow-up.
The sugar control.
Seeing doctors, I mean, those things that I can do at home, but seeing doctors, whoever, the surgeon or their physician in Gleneagles Hospital.
After surgery, first month will be good. Then after that, 3 monthly. Only for the first year.
It's not that intense.
Not that intense. Then after 1 year, we actually will follow up from 6 months to 12 monthly.
Okay.
Yeah.
Not that bad. All right. Thank you everyone. Okay, before we end the webinar, I would like to give this opportunity again to Dr. Chan to give parting words to all of us tonight.
From me?
Yep.
One thing, the way to approach these patients who are obese is, I think we need to understand them, and first to tell them it's not their fault. It's not their fault, and then we should encourage them rather than discourage them when they are unable to reduce their diet or even go and exercise. Actually, we should encourage them and support them. Likewise, because to ask them to lose 50 kilo is not easy. It's the same as me asking you to increase 50 kilo. It's never easy. You cannot increase 50 kilo over the next 1 year. So if we understand that what they go through, then we find what are options available and to take care of it. It's a whole journey for them.
Thank you very much, Dr. Chan. Thank you, everyone. We'll see you again next week. Bye.
All right.